And then, of course, as I said, the new conduit kept pressure on the lung and heart. So whenever it gets pressure on the heart, it can cause the cardiac arrhythmias. All type of arrhythmias are common. Generally, in post-operative esophagectomy patient, sinus tachycardia, you would see patient heart rate around 130, 140s are very common in post-operative setting, and those are self-limited. Sometimes patients go into atrial fibrillation, and ventricular fibrillation are seen but are not that common. But sometimes even patient goes in unexplained cardiac arrest. So with this morbidity, total morbidity or total complication rate in esophageal surgery is around 20 to 25%. Before offering the patient surgery, of course, you need to always evaluate the risk benefit ratio. That is why the indication of esophagectomies are very life threatening condition like esophageal perforation, long term stricture when endoscopy treatment has failed and patient cannot eat. Of course, you can't be having those jejunostomy tubes or tubes in the abdomen for feeding for life, or without food, of course, you are going to die with starvation. So in that case, the surgery becomes absolutely necessary. So in that case only your risk benefit ratio tilt toward offering esophagectomy. With improvement in surgical technique, generally postoperative mortalities are in the range of 8 to 10%, not more than that. Our own series, we have mortality around 5 to 6%. So when we offer that kind of can offer that kind of benefit, then only we have to offer esophagectomy to the patients. Okay, now let me, I will just describe the two cases because here we are going to discuss about complication. So I have not mentioned all those patients who went home uneventfully and were very happy with the surgery. Because to be a better surgeon, of course, you need a better technique. But more than that, you need to know how to manage your complication. In one cases, and how patient compliance is important, because in one case you would say with similar technique we were able to manage the complication, and in one case the patient succumbed, and why patient succumbed, that also we will discuss. Okay, now in this case this was relatively old gentleman, 72 years old male. Patient had history of esophageal perforation 5 years back, and in Delhi Army Hospital, patient underwent initial because whenever there is perforation and active sepsis, we generally do not recommend very high risky surgery. So in that case, patient was given, I would say, what we call is a bailout surgery, and they treated the patient, put a jejunostomy tube, that is the directly tube for feeding in the jejunum, and came out. Uh, After that, patient developed due to damaged esophagus. The perforation was healed automatically, but esophageal becomes structured or very narrow. So he was not able to eat anything. All the feed was going through the jejunostomy tube. He outside, the many gastroenterologists have tried, and rightly so, for endoscopic dilatation, because the first treatment should always be endoscopic dilatation only. But multiple endoscopic dilatation failed. So they came to me, we offered them the surgery. We explained all the risk to the patient, but patient wanted the surgery and get rid of feeding jejunostomy tube, because he already lost 20 kgs, because you cannot give enough calorie, or he was not able to take enough calorie to feeding jejunostomy tube. So we did the esophagectomy. In that case, stomach was damaged, so we need to use the colon. We did the transhiatal esophagectomy with colonic pull-up. So again, surgery was uneventful. Patient was extubated and put off out of ventilator immediately. On post-operative day 3, patient suddenly become drowsy, and we checked his blood CO2 level. CO2 level was very high, and he developed acute respiratory acidosis. We had to re-intubate the patient. Patient was kept on ventilator for 3 days. Generally, over the time, the ventilator, we weaned out the ventilator. Uh, Patient came out nicely. Patient had cervical leak where we did the anastomosis. Almost 50 to 100 ml of leak daily came out. But It was controlled leak and patient was not having any sign of infection. So we waited. And patient discharged with, of course, active leak, but it was all coming into that bag we used. And prolonged hospitalization has its own risk. So we discussed with the patient and patient was discharged. Patient was regularly coming on follow-up. Leak stopped after 2 months. Then patient started eating orally. We removed his jejunostomy tube, and on 6 month follow up, patient is doing totally fine and all now have no complication. So this patient developed complication. He was weak. He was old age, multiple perforation, having feeding jejunostomy tube for long, but still survived. And patient was very cooperative in this case.